Okay, we're going to get started now. So I want to say hello to everybody and welcome to the Spring Pharmacy Forum presented by the Canadian Foundation for Pharmacy. The topic for today's forum is how pharmacists can take action on social determinants of health. My name is Linda Pertula, and I'm the Executive Director of the Canadian Foundation for Pharmacy and a pharmacist myself. I am so excited and privileged to be helping lead an organization that has supported the profession of pharmacy for 81 years now, since 1945. CFP is Canada's only registered national charity for pharmacy, and its mission in 6 words is to help advance the profession of pharmacy. We do that by raising funds for grants and awards that our board of directors bestows on deserving researchers and innovators and leaders in pharmacy. Through our innovation fund, we have granted more than $2.5 million for 40 research projects, many of which have helped prove the value of pharmacy services under the expanded scopes of practice. And our Wellspring Pharmacy Leadership Program provides pharmacists with up to $10,000 yearly in financial aid to foster personal development and leadership. CFP also helps advance the profession through education content such as today's Pharmacy Forum. We couldn't do this without donations from individuals and the support of our corporate partners. If you're not already a donor, I ask each of you today to consider adding CFP to your personal list of charities. It's an easy and effective way to give back to your profession. And a huge thank you for our today's sponsors. They are our platinum sponsors are Amgen, GSK, Shoppers Drug Mart, and Loblaws. Our gold sponsors are AbbVie, AstraZeneca, and Green Shield Canada. Oh, sorry, and Pfizer. Before we get started, I just want to let you know that today's session is being recorded and will be available on our website after the presentation. Also, if you have any questions, please put them in the Q&A section and I will make sure that they are answered. We are pleased to have some great speakers to discuss this important topic. These speakers are featured in in last fall's Changing Face of Pharmacy magazine. If you did not receive a copy, you can always download it from our website at cfpnet.ca. All right, that's enough from me now. I'm thrilled to introduce our moderator for today, Angeline Ning. Angeline is a pharmacist and Vice President of Professional Affairs at the Ontario Pharmacists Association, where she is responsible for helping to advocate for the advancement of the profession of pharmacy by leveraging unique expertise of pharmacy professionals and enabling them to practice to their fullest potential. Throughout her career, Angeline has worked in a variety of different pharmacy settings, including community pharmacy, long-term care, and the pharmaceutical industry, as well as teaching. I'm now going to turn it over to Angeline. Thank you.
Thanks, Linda. Maybe before we get started, I'd like to extend a big thank you to Linda and the CFP for organizing this important event. I'd loved hearing about the history of CFP, and I think your commitment to advancing innovation and leadership within pharmacy practice, including initiatives like today's discussion, is really helping to shape the future of our profession and ultimately health communities across Canada. So thank you very much, Linda and CFP. So today's topic, social determinants of health, I think couldn't be more timely. Across Canada and we're seeing across the world, we see this growing awareness that health outcomes are shaped by more than just medical factors. We see rising inequities in housing, food security, and access to health services, and they're compounded by challenges like the ongoing impacts of the pandemic, mental health crises, and an aging population. As pharmacists, we're one of the most accessible healthcare professionals. Every day, we see patients facing challenges that go well beyond prescriptions, challenges that affect their ability to stay healthy, to access care, or even to store and take medications safely. By understanding and addressing these determinants, we have a real opportunity to make a deeper impact on patient care and health equity in our communities. Today's speakers are here to share their expertise, their insights, and practical strategies on how pharmacists and pharmacy teams can expand their role in identifying and acting on social determinants of health. I'm really excited for the discussion ahead, and I hope you leave here inspired and energized to take action in your own practice. So our first speaker is Tariq Hussain. Tariq is a pharmacist clinician, researcher, and national leader in social prescribing and social determinants of health. He's co-founded and managed independent community pharmacies in Kingston, advancing social determinants of health integration screening and social prescribing into routine pharmacy practice. He serves as the Chief Development Officer of the International Social Prescribing Pharmacists Association and is the Director of Content Portfolio at the Canadian Association of Pharmacy for the Environment. He's a Master of Science candidate at the University of Toronto's Leslie Dan Faculty of Pharmacy, and his research focuses on embedding social determinants of health, screening, and social prescribing into pharmacy practice and education. Tariq brings both evidence and lived practice experience to this conversation and believes that pharmacists embedded in primary care are particularly well positioned to serve as the first point of contact for social prescribing in Canada. Welcome, Tariq.
Well, thank you so much, Angelina. I'm going to share my slides right now. Hope you can see it. Okay.
Yep, very good. Thanks, Tariq.
Still can see it?
Down. We did a minute ago, a second ago.
Just 1 second. Sorry about that.
No worries.
Okay. Here we go. Okay. Okay. So thank you so much, Angeline, for the kind introduction.
No worries, Tariq. Do you mind putting it into maybe presenter view? We can only see a part of the slide. Or maybe not this one. Oh, perfect. One back, whatever you did right before this.
Okay, here we go.
We can see your speaker notes. So maybe, yeah.
Here we go. Can you see it now?
Yeah, now it's perfect.
Okay, all right. Sorry again for for the technical issues. Thank you, Angeline, for the kind introduction. I'm excited to be here today and to share how social prescribing connects healthcare to everyday's realities and that shapes health and what pharmacy can do to scale that up. In the next minutes, I'll try to connect the three dots, what really drives health and what social prescribing is, and why pharmacy can do that, or what pharmacy can do to actually help with that. So, besides physical and mental health, social health is the forgotten pillar of health. When we talk about what matters, what makes people healthy, we often focus on doctors and hospitals. But this slide shows that the most health is shaped by daily life. Things like income, education, early childhood experiences, housing, especially community belongings. Health care matters, but it is only a portion of the picture. As you can see, it's only 25% of this of the reasons why how we can get better as Canadians. If we want better outcome, we can't really just try to treat illnesses as after it appears. We have to strengthen the conditions that prevents it, and this includes connection, inclusion, and belonging. Which leads to the next question: what happens to the social connections today? So the dull green and whitehead model helps us to see it, what we talked about in layers around the person, the lifestyle, the social community networks, living and working conditions, and the broader socioeconomic, cultural, and environmental conditions. In practice, those layers decide whether the patient can follow a plan we design. For example, a perfect regimen is useless if the patient cannot pay for it, cannot read the instructions, or are overwhelmed with other priorities. themselves. So when we say 80 to 90% of health is shaped outside the clinic, we are saying equity won't come from better prescribing alone. We need a bridge from health care to the community support, and social prescribing is that bridge, or can be that bridge, is a structured bridge or a structured way to bridge that gap. So what is really is social prescribing? It is not just signposting. It is a structured way for trusted people in or community settings to identify non-medical health-related social needs and connect someone to community supports by co-producing a social prescription. So as I just mentioned, it's not just signposting, it's a plan built with the person, what matters to them, what they really need, and what they are ready for, and how can we actually make that connection with what is available for them in the community. It is it is more broader than we sometimes assume. It's just not only physical activity, diet, and nutrition. It's more of more to the housing, support, social connection, employability, benefits, advice. All that can be part of a health plan right now, and all that can help our patients. So here's what the process look like from end to end. So as you can see, first, a trusted identifier notices a social need, often because it shows up during a routine interaction, like a refill, a mid check, or a minor ailment consultation. Second, the identifier connects the person to support, sometimes directly or even via a connector or a link worker that we normally call the connectors in most of the time. They also called navigators or community navigators who knows local resources and can follow through. Third, the co-production, there is a co-production and follow-up and a shared plan that clear next steps and adjustment over time. That's why it is called prescription. It is intentional, not incidental. If we go back to our patient from the opening, the intervention might not be another medication. It might be a stable food access, transportation support, or a program that rebuilds social connection. As we can see here, that it matters for the patient. It also matters for the system that is really under strain. Social prescribing can reduce the cycle of crisis driven by addressing what is really driving the crisis, like by really going deep into the underlying causes. And as you can see, there's reduction in feeling loneliness, mental health issues, and also increase in social use of services, which consequently reduce the burden on the healthcare system on the numbers you can see from two different studies in Ontario and in the UK. But the headline would be basically the return on investment. So roughly there is a $4.43 return on investment back to the society for every dollar spent on social prescribing or community activities. So this is really something that quantifies it in our eyes. And so now if the value is clear, how can we plug in as pharmacists? This paper that was published in 2021 by my colleagues at the International Social Prescribing Pharmacy Association can clearly show there is three ways that we can participate as pharmacists, as identifiers. And I think this is a very big role for pharmacists. So we can spot early the early needs. We can because we can see the friction points like cost barriers, complex regimens, missed pickups, or patient who is suddenly less engaged for some reason or another. As referrers, we can initiate the pathway and connect to the hubs. Sometimes you know where to connect, and probably later in my colleagues will share some real examples about that. They can even sometimes deliver certain interventions like lifestyle and wellness kind of activities, and even non-farms. Part of them can be considered as social prescribing. So let's make this real this reel with one social determinant that quietly drives a lot of medication use. And basically, this is where I want to give you a real example of how this practical example of how social prescribing matters for us as pharmacists. This study links the severe loneliness with polypharmacy, in particular gender, which is older women, not because loneliness automatically causes more medication, but because it can flag unmet social needs that show up as more health issues and more prescriptions. In medication reviews, we may see a long list of optimized medications, but we really need to know why this was prescribed. So basically, it is more of a layered interventions that happen time after time, led to all those um, the outcome of having a lot of medications or polypharmacy in medicine. And we can definitely identify that and identify the connection that is missing here. And what is really pleasing for me is, and for most of us as clinicians and educators, is that we have in the latest pharmacist patient care process, they social prescribing or social determinants of health identification are more explicit. It's part of the routine, person-centered care rather than just being an add-on. As you can see in this diagram, I tried to show you where it is mentioned in each of the steps. So when we collect the clinical story, we need also to collect the non-medical context where people live, work, or what are and beliefs that affects care. When we assess social determinants of health should be there, when cultural consideration, health literacy, to pinpoint the true barriers and the most appropriate referrals. When we plan, we have to make the plan as a person-centered, cost-conscious, alongside with medical plan. We also implement through coordination, tailored education, community connections, and then follow up because needs change over time. So this is really important. And if we zoom out one more level, this is where we start to see the impact moving upstream. So this river is a very useful metaphor. Downstream to me is clinical care, treating harm once it showed up, once it's happened. Minor ailments assessment, the midstream where social prescribing kind of lives or resides, when we spot the social barriers early and acting through screening, referrals, warm hands off, and practice support. It's similar to minor ailments for pharmacists. Minor illness to me also resides in the midstream. We are trying to act on kind of temporary issues that can cause problem and can go downstream by just addressing them early on and preventing complications. So it's the same idea. And upstream is the structural work, laws, policies, funding, and community conditions that shape housing, food security, transportation. So we need to push upstream. If we identify social determinants of health and address them on the midstream, we're preventing them from going downstream, and we're trying to push our patients to, or our communities to go upstream. If this is really clear, like what I'm showing, and we are all excited about it, so what is preventing it, or what are the issues that are affecting, or barriers that happening in our daily practice? And I can lump them into basically two barriers that can show up again and again. So barriers in education and barriers in the practice. So basically, social prescribing is really taught explicitly. It is uneven. It's squeezed as something that to mention that we just need to know about in the communities. And in practice, there's no funding. We have lots of workload, and we really need to include how we don't have mechanism to include it in our daily practice. So the transition is to path forward, or the path forward is building an infrastructure to address this missing needs. So this is where I'm going to leave you today that wrapping up that there are 5 levers that we can use to make this scalable through education, by clear competencies in practice and training, partnerships by creating formal pathways to refer and hand off, digital enablement, which basically allows us to capture all the pathways and also have directories where we can refer clearly, advocating and policy changes to allow funding and research where we can have evidence that translates into practice ready models. So together with these levers, we can move from promising pilots and being kind of just frontliners to basically integrating and having the pharmacy as an engine to health equity. So with every conversation, every connection will at a time will lead to more community link and will evolve our role as far as clinicians in the community. So I'll stop here and thank you for the time.
Thank you, Tarek. That was really interesting, and I really enjoyed that presentation. Just a reminder to the participants, if you have any questions for any of the speakers, please feel free to put them into the Q&A, and we'll work through the questions as we go through the different speakers. While we're waiting to see if there are any questions coming through from participants, I thought that slide that you showed about pharmacists being identifiers, referrers, and even providers was really interesting within this concept of social prescribing. I know you own some pharmacies and work on the front line. If a typical community pharmacy wanted to begin this tomorrow, what do you think is like the smallest, maybe practical first step that they could take to start integrating the social prescribing into their routine workflow?
Well, thanks, Angeline. That's a very, very important question. I think the slides I shared about how the patient care model has changed by including social determinants of health is really helpful in that. And I think the first thing that we need to do is we need to really go beyond just filling the prescriptions or looking at the medication, where are the medication problems, drug DTPs, all that stuff. We need to ask a little bit deeper and check, is there anything else that the patient is going through? Like, for example, just a very quick example. If you have somebody's coming frequently for respiratory illness all the time, the whole family, I had this personal experience, and then when I asked the patient what's going on, what's happening, and I discovered that there are molds in the apartment that this person is living on, and it's causing this respiratory illness. So if we don't go and clean the molds or do a referral to housing department so they can move from that apartment, the outcome will never be favorable, because they will always come with acute respiratory illness. They will use a hospital, they will use inhalers, steroids, all the things. But just going beyond that and cleaning that environment that they're living in through a housing intervention would make much better outcome, less use of medication, less use of the healthcare system.
That's a great example, and really highlights sort of the importance of what a pharmacist can do to help with improving health outcomes. So just a reminder, if there are any other questions for Tarek, please feel free to put them in the Q&A. To make sure we have enough time for all the speakers, maybe we'll move on. But thank you so much, Tarek. And again, if there are any questions, we can come back to them. But our next speaker is Tiffany Lee. Tiffany is an assistant professor at Memorial University School of Pharmacy and the director of the PharmD for Working Professionals program. She provides direct patient care as a clinical pharmacist in anticoagulation management with Newfoundland and Labrador Health Services. She's a PhD candidate in community health and humanities in the Faculty of Medicine at Memorial University, and she maintains an active research program in applied health research, with one area of her research focusing on strengthening community-based health and social care via implementation of evidence-based health services. Tiffany is leading the SPARK RPH implementation study, which is funded by the Canadian Foundation for Pharmacy. And this is focused on studying the implementation of a SPARK tool, which is a social determinants of health screening tool at community pharmacy sites in Newfoundland. Welcome, Tiffany.
Thank you, Angeline. A great presentation, Tarek. Hello, everyone. It's my pleasure to join you today and to speak about the SPARK RPH implementation study that's ongoing here in the province of Newfoundland and Labrador. Before I begin, I think it's important to point out that Spark RPH is really a program of research. It includes a few integrated projects with a wonderful team of individuals contributing to this research project, including 2 patient partners who play a central role on the research team. The Spark RPH team also includes researchers from the Faculty of Medicine at Memorial University, the Upstream Lab at Unity Health Toronto, and the Newfoundland and Labrador Centre for Applied Health Research. This study would not be possible without the unwavering support of Dr. Andrew Pinto and his team at the Upstream Lab. I'm very grateful to them, and I'm sure many of them are joining the presentation today, as well as funding that I received through the Canadian Foundation for Pharmacy. So I'm very appreciative for all of that, and projects like this wouldn't happen without that support. As a program of research, Spark RPH includes this implementation study, which I'm going to tell you a little bit about today, but equally important was the Spark RPH public engagement project, which wrapped up in the fall of 2025. So that public engagement project included a series of engagement sessions with citizens, pharmacists, pharmacy students, and community organizations. And that work really informed the development of this implementation study and our path forward for this project. If you're interested in learning more about the public engagement project specifically, I don't have time to talk about it today, but I'd encourage you to reach out to me by email. So you can just email tiffany.lee@mun.ca. Thank you. So I've used the term Spark several times now, and I know Angeline told you a little bit about it already, but just to go into it a little bit more, Spark is an acronym for Screening for Poverty and Related Social Determinants and Intervening to Improve Knowledge and Links to Resources. It was an acronym that was developed by the brilliant folks at Upstream Lab, and it's intended to represent the importance of sparking conversations about the social determinants of health with our patients, colleagues, governments, and so on. So the Spark tool shown on your screen is a social needs screening tool. It was originally developed to address the lack of data on social determinants of health in primary care settings. The initial set of questions was developed by a collaboration of hospitals and a local public health organization in Toronto. Subsequent research, led by Dr. Andrew Pinto and his team at the Upstream Lab, investigated how patients interpreted the questions and how the tool performed in primary care and other settings. So today, the Spark tool is being implemented across Canada in diverse primary healthcare settings, as well as outpatient clinics, and more recently in acute care. This work is being facilitated by the Deep End Canada network. And I would encourage all of you who are in attendance today to take a moment to look up, so just Google Deep End Canada, and you will find a great web page with lots of resources that talk about how you can take action on social determinants of health as well and get involved in the Deep End Canada work. So on the screen, you can see that the Spark tool includes a total of 7 demographic questions, as well as 2 optional questions, and 10 questions focused on assessing social needs. Within the Spark tool, which is primarily across sites delivered electronically, each question has a hyperlinked description, which describes the purpose of the question and why it is being asked. And that feature is really helpful to healthcare professionals when they're, describing to patients why this information is necessary in providing care. So pharmacies here in Newfoundland and Labrador who are affiliated with the Spark RPH implementation study are using this tool to screen for social needs. To my knowledge, we are the only group of pharmacists in Canada currently using the tool. However, it's my hope that the findings of the Spark RPH implementation study may support pharmacists who are interested in embedding the Spark tool in their practice. So as part of the Spark RPH implementation study, 7 pharmacies across the island portion of Newfoundland and Labrador signed on to implementation. So this includes representation from 4 health zones within the province. And given the population distribution here in Newfoundland and Labrador, you'll note that there's more community pharmacy research sites in the eastern urban zones than there are in the other areas. In terms of pharmacy types, we have 3 sites which fall into the category of chain or franchise, 3 independent or banner sites, and 1 specialty or non-dispensing pharmacy. So this study is designed as a multiple case study. We use multiple methods to collect data. Each site was asked to complete a site description form to enable robust case description. So using this information, we will be able to compare and contrast findings across cases and explore implementation facilitators and barriers across the diverse group of pharmacies noted here. I will say that there was a staggered implementation of the Spark tool across the sites. And each site had a 6-month implementation period, or if they reached 50 participants or patients enrolled before that 6-month period, that's when it would end for them. The first site began implementing the Spark tool in June of 2025, with the second site in July, the third in August, and so on. So today we have 3 sites who have officially completed their 6-month implementation of the Spark tool. So at the heart of the Spark RPH implementation study is patient care. And what I mean by this, when I say patient care, I mean health and social care. So as a part of implementing the Spark tool, the pharmacist site champion or champions were required to align the social needs screening with one-on-one patient encounters and services. So based on the literature that I had reviewed from the United States, which has the most significant volume of research publications in this area, I shared with the pharmacists my thoughts on which services made most sense. So this included medication reviews, comprehensive annual reviews, common ailment assessments, and deprescribing consultations. However, as part of the implementation, they were free to identify other services that worked well for this purpose. So during the patient interaction, the pharmacist, as part of this study, reads the Spark tool questions aloud to the patient and documents the patient's response. So they help the patient complete the questionnaire. We chose to use this approach as a way to enable real-time identification of social needs during that visit. Once the social need then has been identified, the pharmacist then proceeds to discuss possible community-based resources and referrals with the patient. So as Tarek mentioned, they do that work to co-construct the next steps in addressing the social need. As a part of the research package that we sent out to the sites, our team had assembled a list of community resources and social supports available in each area, and that's what the pharmacists used. In most cases, here in our province, these supports require the patient to make contact with the social agency directly versus accepting referrals from healthcare providers. Therefore, a lot of the work that the pharmacists did, a lot of that connection work, to use Tarek's word, involved information sharing and facilitation versus actually filling out a referral form. So alongside of the patient interaction, the research is happening simultaneously. So this is applied research. It's truly applied research happening in real time. Research data includes the patient's responses to the Spark tool, so demographic and social needs data, as well as experienced acceptability of the screening intervention from the patient's and the provider's perspective. And then we're collecting data on implementation outcomes. So there are 7 implementation outcomes of interest in this study, and I have them noted on the screen. So once the study concludes, I will have so much information, a wealth of information to share with the pharmacy practice community to help you guys make assessments about the practicality of implementing this at your site. So given data collection for this study is ongoing, and really we've only officially launched phase 1, I'm not able to share much in the way of findings with you today. That being said, I thought it would be helpful to provide some information about the total number of patients screened to date, the types of services that pharmacists attach the Spark tool onto, as well as, some early implementation statistics related to time. But I do want to remind you that the findings here are preliminary and incomplete. So I'll have a lot more information, I would say, in 6 months' time. So as of February 24th, 125 patients have been offered the Spark tool. And of those, only 8% have declined. So the acceptance rate has been very high. This is an impressive finding in and of itself. It tells us that patients are willing to talk to their pharmacist about their social needs. The high acceptance rates that we see here are also consistent with what Dr. Andrew Pinto's work in primary care uncovered, as well as the work of other researchers across the country. And this all suggests that patients are open to social needs data collection when they are told why the data is important to care, how it will be used by the provider, and how it may help them. Other researchers have pointed out that patients often feel listened to and cared for when clinicians ask about their social environment, rather than feeling uncomfortable or judged. It puts the care back in healthcare, so to speak. So for this study, we are still collecting data related to experienced acceptability from the patient's perspective. As I said, I'll have more information to share with you about that in the future. So a second interesting finding that I feel is quite interesting to share with you today relates to the types of services which pharmacists have attached the screening onto. So I went into this project thinking we would see a much higher percentage in the med review category. However, what we see is that pharmacists have attached it to services like immunizations, refill counseling, and so on, with immunizations being definitely more common than anticipated. And in terms of the time commitment, on average, the entire process of administering the tool, identifying needs, connecting patients with resources, and documenting care has taken on average about 16 minutes. However, I will say that there is quite the range here. So some patients start to finish only required 5 minutes, whereas others 65 minutes. So it depends on the complexity, your patient, as you folks know, how much your patient likes to chat with you, and so on. So the most time-consuming part of the process has been administering the tool to identify the social needs. So we're going to explore this further with the pharmacists in much greater detail as we move into phase 2 and begin our qualitative interviews. So at this moment in time, that's really all that I can share with you. I'm certainly happy to answer any questions that you might have. And I just want to thank you for bearing with me. I have a cold today, so my voice is starting to break up. But yeah, so any questions for me?
Thanks, Tiffany. It does look like we have a question that just came in from Ronald. Where and how does a pharmacist start to develop a list of social resources available in their local community in order to bring value to the Spark tool?
So that does require, Ronald, quite a bit of work, of course. It will mean that you will have to not just look at social supports available through government agencies, but also do a lot of digging around community-based groups that provide social care services. The majority of social care in our province is provided by volunteer community-based organizations. And so it did require quite a bit of work to establish that list of resources. That being said, in a lot of provinces across Canada, there's a service called 211. It's 211 because it's easy to remember. Just like 911, you call for an emergency. 211, you call for social care services. 211 online provides you with a list of social care services available provincially. So that's a good place to start to develop your list. You can also refer your patients to 211, and they will have a call with a social care navigator who will help connect them. But yeah, that definitely takes quite a bit of work. I don't want to speak for Tarek, but I think he's doing some work in this area with more information to come about that. So there is quite a bit of momentum being built across the country by pharmacists, by leaders in the profession who want to see this happen in a meaningful way. So I would say keep a close eye out for some of Tarek's work that'll move forward in the future. Great question.
I'm not seeing any other questions, but please feel free to put them in the chat and we'll get to them as time permitting. But I want to make sure we have enough time for the two presenters that are still to come. So with that, thanks, Tiffany, and I'll introduce our next speaker. Our next speaker is Solmaz Nafez. Solmaz is a community pharmacist and pharmacy program leader with over a decade of experience in practice in pharmacy management. She holds a Master of Science in Pharmacology and Therapeutics and a Bachelor of Science in Pharmacy from the University of Manitoba, where she was named Community Preceptor of the Year in 2021. As Pharmacy Program Manager for the SERDC Health Services and Shawano Pharmacy, she oversees pharmacy services supporting urban and remote First Nation communities across Manitoba. Her work focuses on improving access to care in geographically isolated settings, strengthening team-based models, and advancing pharmacist-led clinical services to address social and structural determinants of health and to promote health equity. Her experience offers a practical frontline perspective on how pharmacists can advance health equity and strengthen care delivery in underserved communities. Welcome, Solmaz.
Thank you very much for your kind introduction, Angeline. And thank you for having me for today's conversation. I definitely enjoyed Tarek and Tiffany's talks very much. I did not know about 211 services, Tiffany, and I believe a lot of us didn't. So thank you so very much for that. So let's start with my talk for today. Bear with me for a quick second. Can you all see my screen?
Yes, we can.
Okay. So my name is Solmaz. As Angeline mentioned, I'm a community pharmacy working as a pharmacy program manager of SERDC Health Services and Shawano Pharmacy in Winnipeg, Manitoba. Today, I'm going to share a practical view of social determinants of health, what they look like at the pharmacy counter, and what actually helps. My goal in the next 10 minutes or so is that I want you to leave with a clear picture of how we turn barriers into workable plans. To start, I'll give you a quick snapshot of who we are at Shawano Pharmacy and why our context matters for this conversation. So Shawano Pharmacy is First Nation-owned pharmacy in Winnipeg, and we are owned by the 8 First Nations of Southeast Resource Development Council, or SERDC, which is one of the 7 tribal councils in Manitoba. We have been operational since 2018. I joined this pharmacy in 2023, and we are partnering with SERDC to support First Nation health services. Over 95% of our patients are First Nations. Over 80% of our patients live in remote fly-in communities. And I don't know how much you know about fly-in communities, but all they have in terms of healthcare is a nursing station that is built and run by Health Canada. That's for kind of acute and emergency care. For very serious conditions, obviously they use Medivac system. There is no hospital, no pharmacy or walk-in available for these communities. So we are the only pharmacy in Manitoba delivering medications, including ward stock and medical supplies and equipment to our nursing stations. And basically, we're serving the 5 nursing stations of Southeast or SCRDC. The other 17 nursing stations in Manitoba are being provided by Indigenous Services Canada directly. So we are the only pharmacy who got this contract through SCRDC to help these flying communities. Also, as of June 2025, we have been ordering and distributing medical supplies and harm reduction products to over 43 health centers in Manitoba. A big part of our daily work is bridging the gaps that patients run into on a daily basis. The most part is NIHP coverage issues, including prior approvals, transportation barriers, access to supply, and Jordan's principle of navigation. So here's the simplest way I frame social determinants of health in pharmacy. Behind a misdose, there is usually a barrier, not a non-compliance. In other words, if we don't identify what is going to stop the care plan, then our care plan becomes more of a wish than a strategy. In our practice, we try to detect barriers early and build around them before things start falling apart. So these are some of the barriers that we have to deal with on a daily basis. Basically, transportation and distance are huge, and it can be affected by weather, flights. Majority of the time, flights are canceled due to bad weather. Transportation can easily derail refills. So we plan proactively. We synchronize medications when possible, and we ship early so patients are not going to, or they don't have to wait until the last minute for their medications to arrive. And as you know, there is no pharmacy there. So if they don't get their medications, there is nothing for them. There is the next barrier is the safe storage. That's a real issue for some of our patients. Not every home has reliable refrigeration or secure space, so we plan for that too. We communicate with nurses in nursing stations. We do have a medication room in each of these flying communities nursing stations, and we have fridges in them, so we coordinate with the nurses and we take care of the medications that are absolutely need to be refrigerated, so patients don't have to worry about that. Food insecurity, of course, is also matters. If someone does not have consistent meals, it affects tolerability, adherence, and outcomes, so we try to align therapy to what is realistic. And again, that happens in conversations we have with nurses or nurse in charge in nursing stations. Sometimes they're physicians. On this topic, I need to add an example that I had to deal with, and this puts everything in perspective. A while ago, a nurse from Little Grand Rapids called me in a very panicking mode. So they had a like a newborn, an infant, 1 month old at the time, who could not tolerate any formula but one special kind. And they had coordinated with us. We had got the prior approval from NIHP, a non-insured health benefit, under the infant's mom's treaty number. And this is another barrier that a lot of First Nation patients actually have to go through if the pharmacy doesn't know how to process their medications or medical supplies. So that part was done. But and basically my staff had been waiting for nurses to call and order a refill. So this time, obviously, the infant is growing, the frequency of feeding is going up, and somehow it was missed, and the nurse calls very last minute. And of course, it takes a day or two because we fly our medications to Little Grand. So they didn't have anything. So the nurse said, the whole night I've been feeding this baby with sucrose, and it just broke my heart that there's nothing else in the community to help them. So what I did at the moment, so immediately we managed to send the emergency supplies to the community. It still brings tear to my eyes because this is so unfair. But also, you do imagine there is no other pharmacy there for them to go to. There is no other way to get these supplies, and this is food. So anyhow, we very urgently we delivered it. I coordinated with our airlines, and they got it, and I immediately contacted the physician, and I wrote everything for the physician that this is the situation, we need to increase the frequency of feeding, and the physician actually did that very quickly. But by the time we took care of the prior approval, again, we applied for everything, the baby had the food. But this is how important is the work of the pharmacy when it comes to barriers to care. And moving forward, I made it mandatory for all my staff to synchronize medications for our patients, especially in remote communities. So to obviously cultural safety and trust matters too. If people don't feel safe, they won't engage, and no clinical guideline can fix that. So we build cultural safety by leading with respect and choice. We explain the why. We let the patient and community set the pace for us. And of course, for system navigation, we always prioritize access through non-insured health benefit prior approval. It is a very lengthy process. It's basically the difference between access or no access. We have trained staff who communicate with prescribers. They prepare paperwork. They follow up with the NIHP on prior approval until we get the access for our patients. How do we do it at Shona Pharmacy and at the nursing station? So I gave you an example of how we collaborate with our nurses. We shared visibility on pickups, missed doses, and barriers. We also have on-reserve medication coordinators who are hired and trained by Shabana Pharmacy. They play critical role as they help with delivery to our patients who cannot come to nursing station to pick up their medications. They do kind of chat with them. They get their unused medications. They send it back to pharmacy, and they let us know about the patients. If the patient, for example, they call and say this patient had 3 unopened packs from 3 months, so she's not taking the medications. And with the help of them, especially for elders who do not know English, our community workers are translators, and they help us get to the bottom of the problem and try to make them as compliant as possible. The other barrier that we try to overcome with is the safe administration of injections for people who have fear of needles or they don't have refrigeration. So we coordinate with the nurses. We deliver directly to nurse in charge. We deliver their medication, and Canada Post usually doesn't do refrigerated items, but we do. So we deliver it to nurses directly, and we coordinate the schedule for injections for patients to go, for example, once weekly and get the injection done. Also, logistics are a big part of our success. We often ship medications 1 or 2 weeks ahead. We do have 2 scheduled shippings. So if something is missed in the first shipping of the week, it goes on the second week. We also have emergency and fast track shipping for our patients. And this is very pharmacy specific. We do supply products. So the nursing stations, they do not have doctors all the time, but majority of the time they have nurses in charge. Nurses and LPN are not authorized prescribers in the province of Manitoba, unfortunately, but we are for a lot of supplies, obviously within our scope. For that, we are since I started working at this pharmacy, we prepare templates, so prescription templates with everything that needs to be documented, because they are our first point of contact with the patient. They do the interview, they get all the information, they put it on that form, they send it back to us, and our pharmacists here communicate with the nurses. They finish the prescription that is covered by NIHP, so we provide them with supplies and we send them over. And also we take care of their sharps containers that are or waste, medical waste, expired medications. Our community workers return them to pharmacy, and we cover their costs, so they don't have to be worried about it. And then we dispose of them properly at the pharmacy. How do we support Manitoba health centers? For the most part, health centers are community-based clinics that provide frontline primary care and public health services, especially in the smaller towns and many First Nation communities. Basically, these are the ones that are close to drive-in communities or communities that have a walking clinic or a primary care center within 30 to 35 kilometers radius around them. So the health centers usually stabilize patients who go there for help and refer them to walk-ins, urgent cares, or emergency rooms when necessary. But even then, access can still break down due to affordability and transportation. A lot of patients don't have any mean of transportation from health centers to another location. In that setting, what we started to do to help them, and mind you, we were brought on board to provide them with public health supplies and harm reduction supplies. But Government of Canada, Indigenous Services Canada, decided when we started serving them, decided their focus must be mostly on public health and not primary care. So they removed a lot of items from their formulary. So you can imagine 43 panicking nurses and being mad for losing a lot of supplies for their patients. So what we did, we created, and this one we did it in collaboration with Indigenous Services Canada, the public health nurses. We immediately came up with templates for Indigenous Services Canada to circulate to those health centers for all the items that or products that can be prescribed by our pharmacists, and all our pharmacists here at Toronto Pharmacy are on board with that. And this is how we make those products accessible to them. They do order their supplies. We also send them their patient-specific supplies. Last service we just currently added is the home care kit that we came up with the idea from our home care nurses in our communities. So we put a home care kit package together for them to make their life easier, especially for home care nurses. And we made sure majority of the items in the kit are covered by NIHB in case they need it for a patient. I mean, obviously they need it for a patient, but if they take the 2 minutes to fill out the template we sent them, we can get coverage for them from NIHB, and that has helped them a lot. I did have a meeting with some of the nurses, the First Nation nurses, yesterday about this, and they are very, very much excited about it. So this is also reminder that proximity is not the same as access, and health centers can connect patients to primary care, but care can still collapse if transportation and affordability are not solved. And this brings me to what we are building next, which is a clinic model that is designed around these barriers. And actually, I was thinking when Tarek was talking about social prescribing, and I'm like, oh, that's what we are trying to do here, but I didn't have a term for it. So thank you very much for your presentation, Tarek. It's a very interesting topic. So this clinic model that we are developing right now, it is a team-based an appointment-based team care approach, where the pharmacists, nurse practitioners, and registered pharmacy technicians work together. And we are planning on adding the social worker. And when Tiffany started talking about the sparks, I thought, how amazing. And for me, community pharmacists not knowing any of these terms and thinking about how we can help our patients, it's phenomenal. And now I have words for all of them. So on the core services that are offered in this clinic will be basically focus on same-day care where it is possible, and prescribing if appropriate, chronic disease management, ordering lab works for patients, immunizations, and virtual physician support when needed. And from a social determinant perspective, the value is that the supports people need to actually get care are already built in the pharmacy. So medication access and NIHB navigations are integrated. We know how to support prior approvals, transportation. We already have in place. That is part of this model to reduce missed appointments. So that helps with coordinated care with fewer handoffs, as Tarek mentioned. I was thinking, oh yeah, this is the midstream, but we're trying to push it upstream, Tarek. So for that, I'm very grateful to know that this is how other people have done research on it, and that this is how it's being viewed by other healthcare professionals. And continuity and cultural safety that we provide already for our patient base. This is also there, and that can support adherence. So my closing statement is very straightforward. If we don't identify the barrier, the plan is not real. The most useful question you can ask is, what will stop this plan from happening? And as Tarek mentioned, it takes that 5 minutes. Yes, I have worked in community practice. It's the workload is very high, stress is very high. But believe me, even in that high stress, if you care enough to take that 5 minutes to communicate with your patient, you can ask these questions. And I work with geriatrics in a very busy clinic, and I made it happen there, and I know it is doable. And once you name the barrier, you can design around it, simplify the regimen when possible, and build supports into the workflow. Then follow through, obviously, confirm pickups, deliveries, follow up if something was missed, and coordinate with the healthcare team. And the bottom line is, in short, social determinants of health are not a concept. They are the difference between a prescription and delivering treatment. And pharmacists are vital in closing the gap, because we are accessible, we are trusted, as Tiffany showed with numbers, and we are able to turn barriers into workflow plans. Thank you so much for listening, and I'm happy to take questions.
Thank you so much, Solmaz, and for sharing that very personal example of what you've experienced and how you've helped in your community. I think that was really touching and helpful to show us all, the impact that pharmacists can make. I'm not seeing any questions in the Q&A for Solmaz, so perhaps we'll go straight on to our final presenter for today, and then we can certainly circle back to questions if there are any at the end. So our final speaker is Sarah Kozusko. Sarah is a community pharmacist and pharmacy manager dedicated to improving care for people who are often underserved by the traditional health system. Her work focuses on harm reduction, substance use care, infectious disease screening, and reducing barriers to access. She has led innovative community-based initiatives that integrate pharmacists into broader social and public health efforts. In recognition of her impact, she was named Regina Citizen of the Year in 2021, was a finalist for Woman of Distinction, and was awarded the Queen Elizabeth II Platinum Jubilee Medal. Today, she'll share practical strategies for how community pharmacists can better understand and address the social determinants of health in everyday practice. Welcome, Sarah.
Thank you guys so much for having me. With regards to time and just being a little bit faster with everything, I thought I would just quickly, instead of showing you my slides, go through my presentation a little bit more quickly. So my name is Sarah Kozusko. I run Queen City Wellness Pharmacy in the Heritage neighborhood of Regina, and I'm a community pharmacist. But that isn't what makes what I do exciting. I don't do a ton of things with blood pressure targets or cholesterol ratios. The majority of my day is more, I like to say, at the intersection of healthcare and survival. The people that walk through our doors are primarily people surviving intergenerational trauma, people living with the most complex of mental health needs, people who are houseless or housing insecure, people living with substance use disorders, and most of the Regina's LGBTQ2S community. And why do they walk in our doors? They maybe just don't feel like they fit anywhere else, and everybody fits with us. They're humans. And if we don't understand where they're coming from, and if we don't understand that context, how can we understand their health at all? So I want to tell a few quick stories to kind of outline where we are and where we got to where we're going. The first person I want to talk about is a lady I call here Jane. I've changed everybody's names. Jane was one of my favorite people. I'll say that about everybody that I talk about, but Jane changed the trajectory of our pharmacy. Jane had severe lung fibrosis. She had HIV, heart disease related to substance use. She likely had FASD and significant cognitive impairments. Jane was loud and she was clear and she was unapologetic. She would come in the pharmacy screaming at the top of her lungs, Sarah, and just yelling for what she needed. And she needed to be the first person in line and the first person there. And I just loved her. She would come in with like a crinkled up $5 bill and try to pay for chips and pop, because at that time we were selling that. And I just hated taking her money because I knew she didn't have any. And I knew what she had to do to get that money. So I would just give her the chips and the pop. And soon I was doing that for everybody. And that's not sustainable and it's certainly not healthy. So we stopped selling chips and pop and we brought in fruit. Started with apples, and then we started bringing in bananas and oranges because people didn't have, the greatest teeth. And we'd bring in some cheese strings for protein and snacks. And that was the beginning of our food program. And we now feed over 200 people a day. Jane also would walk in without any shoes on, and in the middle of the winter, like no shoes. And I would have a pair of shoes in the back and I'd have my boots that I wore that day to work. And so I would give her one of my pairs, and then I'd go home and tell my family that you need to bring all your mitts and all your boots and all your things. And that started our clothing program. And now we always have a ton of, our whole boardroom is just storage of clothing. It looks like a hoarder's place because we always have things to hand out to give to people. Jane would go to the hospital and she would leave in a hospital gown because she didn't think they were giving her right meds. And I would convince her to go back. I'd put her in a cab and send her back. And I would tell the nurses she needs to finish her treatment. And they would call me and tell me what needs to be done. And we would coordinate and really executive function for her. She was complicated and she was demanding and she was honest. And I just loved her so much. On our first day of National Truth and Reconciliation, we sponsored a traditional feast. And Jane sat right beside me and taught me where to sit and what not to throw away and how to do it properly and who brought what containers for what. And she was so proud to teach me. And it really showed it was like a real relationship. It wasn't just transactional. It was a real relationship. If I were showing you my slides, I'd show you slides of Maslow's hierarchy of needs, but I'm sure everybody's kind of seen it. And what I wanted to point out with that is, like, we didn't start handing out food because we wanted to be charitable. We started it because it was clinically necessary. You can't counsel somebody on their medication adherence when they haven't eaten. You can't discuss long-term cardiovascular risks with somebody who doesn't know where they're sleeping tonight. When basic needs are unstable, health becomes secondary, and it's not irresponsible. We like to think that people just don't care or they're apathetic, and that's not true. It's biology. So I'll give a quick overview of a few other stories that kind of outline how I noticed barriers and what I kind of did to solve them. So this is all from years ago, the beginning, and it's kind of become day to day now. So Amanda, somebody who was HIV positive, in and out of hospital, like with very violent injuries. One day she almost got decapitated. And every day she'd go into the hospital and I would be wondering, she's going to come out starting on HIV treatment. She's going to come out starting on HIV treatment. There's got to be this team of people that wrap around her when she gets to the hospital and be like, you have HIV, we need to get you treated. Never happened. So I had an offside conversation with a friend of mine who is an ID doctor. And I said, why isn't this girl being put on therapy? And he's like, we probably don't even know she's in the hospital. So I took it upon myself. I had the conversation. I said, Amanda, why aren't you on treatment? If you just took a pill every day, you could die of a heart attack at the age of 85, just like I'm going to. And she's like, I didn't know I could be. And I was like, what? So called my friend, got her in. Amanda's now living in BC. She's got a full-time job. She's raising her grandkids. That was the turnaround. She comes into town to see her mom every once in a while, always stops in to see me. And for some strange reason, she says, I'm the reason that she's this person. And that is not on me. I can't even, I'm like shocked that she would even put that on me that I had, but I was a catalyst. I just asked the question, And she took it on herself when she knew her HIV could be treated to make these changes in her life. Trent, he was homeless and HIV positive and had severe bacteremias. He was in and out of hospital for as long as I've known him. Trent has since passed away. He used to love going swimming in the middle of the summer, and he'd come in after leaving the hospital again, AMA. And I said, Trent, why do you keep leaving? You know that if you don't stay at the hospital, you're not going to be able to go swimming this summer. Like, you're going to be unwell. And he said, I'm sick and tired of staring at four walls all day, Sarah. And I said, what do you mean? Like, it doesn't even cross your mind that he wouldn't have a phone there to watch Netflix on. And I said, well, didn't they give you TV? He said, no. I said, if I can get you a TV, will you go back? And he said, yes. So I made a bunch of calls to different places, got him a TV, and he stayed and got his treatment done. Last story I'll give is Martin. He had advanced infections and likely was facing amputation, totally homeless. And he wouldn't go to the hospital because whenever he went in there, they said to him, what do you use? Like, what are you on? And he'll say fentanyl. He goes, well, you won't get that here. And he would just leave because they shut down the interaction before the treatment ever began. In every one of these cases, the issue wasn't intelligence, it wasn't motivation, and it wasn't morality. It was friction, it was dignity, and it was a system that was not built around reality. It was us putting our expectations on other people, which we can't do. So while this was happening, we started to notice that Saskatchewan we didn't notice this. We know this. Saskatchewan has the highest HIV rates in the world, one of the highest HIV rates in the world. And it's largely driven by IV drug use. But most of our clients were being tested for HIV or hepatitis C at all. So we started the first in-country pharmacist-led HIV point of care testing. And that changed so much. It wasn't just a testing, it was taking away the stigma. It was having a conversation with every single person that walked in the door, regardless if it was my aunt that came in for the day or an old farmer or one of our people that we know is working on the streets. We would say, when was your last HIV test? Everybody should be tested for HIV. Can we do a test on you today? And we didn't profile anybody. We just normalized the conversation. And we told everybody coming in, that if you're on HIV medications, it's very treatable. And that was amazing. We found a number of people that had HIV, a number of people that had hepatitis C, and we started them on treatment. And then we started thinking, if HIV is treatable and we know it's preventable, and we know there's PrEP available mainly in our MSM population, our men having sex with men population, why aren't we doing this in our IV drug using population? So we started the first in-country, maybe in the world, pharmacist-led initiative for PrEP for IV drug users. And we still are running that to today. When the pandemic started and the needle exchange ban stopped going around, I was like, this is going to be a disaster. It was. So we took over needle exchange. It wasn't easy to get all those things going. It wasn't glamorous, but if you can speak the financial language to people at the same time you're speaking the human language, you tend to be able to get things done. And harm reduction is cost containment, and it's cost, it saves the system a lot of money. So what do our barriers look like? So our barriers are people don't have ID. They don't have a fixed address. They don't have a bank account. They don't have a phone. And they've got trauma responses anytime they work into a government office. So people would go down to the social service building and be told they needed identification, a bank account, proof of address. If they didn't have one of these, they couldn't get any of them. It was just horrific, and they would just walk away. And then they couldn't afford to get their medications done because they weren't covered under social services. And so this isn't because they didn't care. It's because the barriers felt insurmountable when they were already overwhelmed. So I started having conversations with Ministry of Social Services, and now we have a full-time social worker in the pharmacy 2 days a week from the ministry that just assists and set intakes. Another example is I got a call one day because Barb was about to be breached on her community treatment order because she'd missed her injection, and that meant she would go to jail because she wasn't getting her psych injection. They couldn't find her. Somebody finally decided to check PIP and saw that she was getting her methadone every day from us. So she wasn't missing. Nobody had looked for her. She was surviving. So I just said to her, do you want me just to do her shot here? And they were happy with that. And she was so grateful because she wasn't trying to be non-compliant. She just had higher priorities, the remembering of an appointment. And that is what the social determinants of health look like in real life. This isn't apathy, it's bandwidth. So I like to say that what we're doing differently in our pharmacy is we're a safe space, full stop. Everybody is safe when they walk in the door. And a safe space does not mean that we are keeping Joe safe from Sarah. It means that Joe is safe today. It means that we know that he's going to be in a safe space, that nobody is making him trade sex for drugs, that he is not, being beaten up for this. As long as he's in our space, he's safe. And we could do this because we built a place where the people already were. And that meant that the systems, we didn't have to chase the systems. The systems came to us because we have the people in the pharmacy that were already, that the systems were looking to connect with. At any one time, there will be 5 people sleeping on the floor in my pharmacy. We've got a coffee bar. People will be sitting around drinking up a cup of coffee. And the reason we have all that is because we have a store cookum. And that was our answer to a security guard. So instead of getting a security guard, we got a store cookum. And she makes sure that our space is culturally safe. Cookum is, the Cree word for grandmother. So she makes sure that the people are culturally safe. She makes sure that it's an LGBTQ2S affirming space. She provides trauma-informing care. But she sits up there and de-escalates situations before they ever happen. She'll hand out, I always laugh and say, she'll hand out a licking and a hug in equal measure, just like any good grandmother does. And that is how we solve what people would think would be a dangerous place to work, is just having somebody up there that loved them and respected them. And all of my staff loves and respects everybody that walks in the door. I am so proud to say that today in our pharmacy, we have a full-time nurse practitioner that does primary care, meaning she does cleans wounds and provides antibiotics. She does preventative health care. She treats diabetes and starts birth control and does pap smears. Our street working women are now getting pap smears. These are things that have never happened for this community before. And we're the only place that is doing this where people are. The health region comes and talks to me about things all the time. We have STBBI testing in the store weekly, and we have done innumerable bacillin shots for people because our syphilis levels are just so high. We have social services in 2 days a week. We have housing intake workers 1 day a week. We have partnerships with every organization that helps houseless or housing insecure individuals in Regina. Even CRA and Service Canada comes to see us once a month. We run NA meetings once a week. We run women's groups and sharing circles and traditional circles another day a week. And we have access to social workers in there that can directly bill to non-insured health benefits that will see our clients on a walk-in basis for trauma-informed care. And you might ask, well, who cares? We're pharmacies. Why are we doing this? When the social workers are in our pharmacy, I can literally walk somebody over there and I can translate the process. I can help problem solve their missing IDs, and I can help executive function for people who otherwise would have walked away before their applications were complete. So this means housing, this means income support, and this means stability. And stability is way cheaper than crisis care. I'm going to skip over some of this because I know some of it was covered by some of my other people. And I'm just going to wrap up with 2 quick things. I'm going to just read out quickly what I put on a card that I sent to all of our clients. This 2 Christmases ago. It's now expanded past this, but it said, this year we served 25,000 meals, 30,000 cups of coffee. We sent 2,000 people to the doctor. We connected hundreds of people with housing coordinators, and we helped more than 300 people obtain government-issued identification. We handed out countless hugs. We clothed people. We dressed wounds. We smudged. We sweated. We danced. We laughed, and we smiled. And none of this could have been possible if you didn't fill your prescriptions with us. So I sent that out as a card to all of our more traditional prescription customers. I'll wrap this up by giving you the rest of the story about Jane. Jane died 3 years ago, and her mother gave us a star blanket that now hangs in our pharmacy. And Jane taught me something simple. Like when you really look at people, you can see what's missing. It's all about like really looking and listening in. Then you can't unsee it. And that's when we realized like pharmacists we're the most, I want to say we're one of the most, or if not the most important healthcare professionals, because we are the most accessible and we're there. So it's just about us opening our eyes and listening and paying attention to the people around us. And my contact information, if anybody needs it, I'll just put it into the chat for people afterwards. And thank you guys so much for having me, and I'll turn it over to the panel.
Thank you so much for sharing all of that, Sarah. I think today's webinar, even though we went a little over time, the comments in the Q&A really capture it. Like, I wish everybody could see and hear from the panelists and experience the stories. I love that we've gone from Tarek, who, set it up for us, explained to us what social determinants of health are all about. Tiffany with her research and the tool that can help you implement it. Solmaz with her pharmacy and how she helps her community. And then finishing with Sarah and these stories that really just touch your heart. So thank you so much to all of these presenters, for all our presenters for sharing and taking the time to present today. I want to say, like, what I've learned is that addressing these social determinants of health, it's not just about adding one more task to our workload. Like, we think so much about burnout and capacity to be able to do all these things and administrative burden in pharmacy. It's really about seeing our work differently. And I think I can see that through listening to all of you talk, and pharmacy being one of the most consistent points of contact in a patient's sort of health journey, makes the opportunity for and responsibility that we have to turn this awareness into action so important. So I'd like to thank all of you from the bottom of my heart for taking the time to share all this with us. And maybe I'll turn it back over to Linda for some final words.
Oh, Angeline, you wrapped that up so beautifully. I couldn't have said that better myself. And I want a big thank you to all of you. I mean, you guys are so inspirational in what you do. It was a fantastic discussion. And everybody who's still on, if you want to hear more about this topic, please go to our website at cfp.net. Our last fall's Changing Face of Pharmacy was dedicated to this topic, and you can read more about the presenters today and their articles and other important information. Excuse me. And as the profession, just as in summary, as the profession continues to evolve, so does this foundation. We've just opened up our submissions for grants for 2026. Based on the survey that we did last fall, we'll be focusing this year's research on enhancing Canadians' experience with care and access to medication services. We're going to be granting $150,000 again this year, with $50,000 dedicated to Move the Needle projects, which are short pharmacist-led projects to help move this profession forward. Details about it all can be found on our website. So in closing, I'm just going to, just wanted to thank our sponsors. Oh, I don't know if you can you see that, Angeline?
No slides.
All right. Anyway, it's in closing. I just wanted to thank our sponsors, our platinum sponsor, Amgen, GSK, Shoppers Drug Mart, and Loblaws. Our gold sponsors, AbbVie, AstraZeneca, Green Shield, and Pfizer. Thank you so much for joining us, and enjoy the rest of your day. Take care. Bye-bye. There we go. Enjoy the rest of your day. Take care.
Thanks, Linda. Bye, everyone.
Bye.